Thank you very much. This is a TCTAP 2016 wrap-up session on transcatheter aortic valve replacement. I am truly privileged and excited to have as our three interviewees some of the world's experts in this particular field of transcatheter valve therapy. So furthest from me is my colleague at Columbia, Susheel Kodali, who is the director of the Structural and Valve Program at Columbia University and New York Presbyterian Hospital. Next to him is Eberhard Grube, one of my oldest friends and one of the pioneers in this therapy, and has had access to many different devices from the early stages to the present, that has pioneered some of the new procedural changes and has really helped us to understand how to use this technology. And closest to me is, again, one of my great friends who I've worked with now for more than 20 years, Alain Cribier, who some people call the father of TAVR. He had the opportunity to implant the first device during the early difficult years, and now continues to innovate and teach us how we should be using this technology in the future. So we're going to try to have a discussion on a variety of topics that would allow us to update the current status and perhaps even project into the future of where TAVR is going. Let's begin by talking a little bit about some of the long-term outcomes, because one of the sensitivities of TAVR is, are we as durable as a surgical aortic valve replacement? So we need to begin to address this issue of durability. So, Susheel, maybe you can quickly review some of the data that you're familiar with in terms of the 5-year outcomes from the PARTNER trial.
Yeah, I mean, I think what we have at least is 5-year core lab outcomes from PARTNER 1A and PARTNER 1B, showing that the gradients remain stable and the valve areas remain stable. The issues, though, are it's a limited data set. It's a high-risk data set. You know, there's in the PARTNER 1A, there's about 50 patients, and the other one there's probably about 30 patients. So, you know, it's probably less than 100 TAVR patients at 5 years, but it's echo core lab data. It doesn't show any evidence of deterioration in terms of gradients or valve areas. And with the taking that further, core valve has some 3-year adjudicated data, again showing no early signals. So we don't have long-term data, but we don't have early signals. The issue that came up last year was when the New England Journal article from Raj Makkar about subclinical leaflet thrombosis and how that potentially plays into durability, and those are the questions where people are starting to raise now, and you know, whether that sort of warrants, you know, closer investigation, further investigation, whether that will impact long-term durability. I think those are the sort of the questions.
Sure. So, Eberhard, you've got some anecdotal data, and Alain, you've got data in patients beyond 5 years. Have you seen any evidence of systematic structural valve deterioration at an earlier stage that would cause you to be concerned?
No, we really don't have any signals, any signs of any deterioration of the core valves that we've done out 10 years, 12 years, and I don't see any. Those are obviously not big numbers, but there's a good follow-up, and there's actually no sign that indicates that we have to worry about, in the long term, worry about degeneration of the valves.
Yes, actually, we have the same observation with the Edwards.
Yeah.
In our experience, you know, we started in 2002, and amazingly, I must say, we have never seen, I think we had one case of deterioration of a valve in our series. And so this is very promising. But however, I would note that the majority of these patients were octogenarians. So now that we are moving to intermediate or lower risk patients, younger patients, it is possible that we will finally have some deterioration of the devices in younger cases, in younger patients. So I look forward for the long-term results of the PARTNER 3 trial will be extremely interesting, because you are including patients over the age of 65.
So we expect that we'll have some younger patients to look at. I mean, we have anecdotally seen some cases of late valve stenosis, which we think represents an element of structural valve deterioration. But it's very hard to say that it's any different than the current surgical valves.
Yes, absolutely. Yeah, sure.
We've had a couple anecdotally in dialysis patients. They calcified at 3-4 years, and it was calcified deterioration. But we've seen that with surgical valves in dialysis patients as well.
This is often associated with renal failure.
Yeah.
And so these are a special subset of patients.
So some of the exciting new data that's been presented recently and some of the ongoing trials really start to deal with the issue of how we get into the lower risk patients. And, you know, this classification is rather arbitrary. I'm not satisfied by it. It's more of a regulatory artifact than it is something that's real. But still, the FDA and other regulatory agencies require us to look at different cohorts of patients. So most recently, there were data looking at so-called intermediate risk patients with lower STS or log Euro scores, less comorbidities, still not very much younger. We're still talking about octogenarians. But to see if in groups like that, the results were as good with the new generation or the current generation of TAVR versus surgery. So maybe, Susheel, in a few words, you can describe some of the outcomes from Partner 2A and the propensity score analysis that were presented at the ACC.
Sure. For Partner 2A, in terms of the primary endpoint, 2 years of all-cause mortality and stroke, there was non-inferiority with SAPIEN XT versus surgery. But some important sort of subgroups with that is when you start looking at transfemoral approach and an as-treated analysis, there was superiority at 2 years for the primary endpoint for transfemoral TAVR with SAPIEN XT versus surgery. And I think it's a relevant analysis to look at because the reality is that's a very different procedure than non-transfemoral.
Yeah.
It is how majority of procedures are done these days. And this trial was in 2011. And then subsequently, the SAPIEN 3 Partner 2 trial was a registry of 1,076 patients and was propensity matched to the surgery arm of Partner 2A. And it showed, through this careful propensity score analysis, a superiority for not only mortality but stroke and the combined endpoint of mortality and stroke at 1 year. And when you just sort of look at the time to event curves, really, you see the difference. In these older patients, as you mentioned, they're still in their 80s. The recovery from a transfemoral procedure that we've all seen is so different than recovery from surgery. And this early separation in mortality occurs at 3 months. And after 3 months, it's level. It's that 30-day mortality of 1% versus 4% in surgery that really dictates all of this difference.
You know, it's interesting. I think that CoreValve predicted some of these outcomes because they had already begun to show, even in some of the slightly higher risk patients, that there may be a difference favoring TAVR versus surgery. And I think that these studies recapitulate that. And I feel pretty strongly now in randomized studies, over 3,000 patients, that we have evidence to be able to say that if you can do percutaneous transfemoral TAVR in these so-called intermediate risk patients, that it's better for the patient than having open surgery.
I think that's a very, very important point. I mean, an incredible amount of patients are being randomized, are being studied.
Yeah.
It's never been done before. And I mean, there's the whole trend goes into that direction. It's being confirmed by registries and by those match trials and by randomized trials. I think we're looking into a great future, and the earlier rosy prophecy, it looks like, finally comes true.
Well, actually, I must say that this randomized trial has been a real important milestone. Yeah. This has never been done before, and it's absolutely important. But we have to take into account what is done in real life, and especially in Europe. I must say that today, not only intermediate cases, but low risk cases above the age of 80 are regularly submitted to TAVR. Yeah. And interestingly, these patients are sent to us by the surgeons. In Europe, this is the way it works. A patient who is not octogenarian, whatever the risk, just because of the age, the surgeons prefer and advise the patients to have TAVR. So this is interesting, but we have more and more patients, low-risk patients above the age of 80, and the results are excellent. And, on a human point of view, avoiding in this older population to have the chest open, the extracorporeal circulation and all the stuff, the long-term rehabilitation and so on, they can now be discharged within 3 days in 70% of cases. They are going back home. They have no pain, no scar, nothing. So I think on a human point of view, it's very logical, according to the results that we have.
I absolutely agree.
Yeah, I think that I'm sorry. That's what we do in Europe. I mean, everybody essentially above 75, definitely above 80, regardless of the STS score, is being treated with TAVR today. But this is a confirmation of what we do. And I think it's important still that we have those data readily available.
I mean, this also, for me, changes the way you look at things, right? So we keep, we start off the conversation about durability, but what is durability in an 80-year-old versus 70-year-old may be different. Average survival for an 80-year-old is less than 10 years, so 15-year durability doesn't matter. Now, if you have a therapy that's superior, and maybe let's just even say that the valve failed at 7 or 8 years. We haven't seen a signal for it. But if they could get another valve at that point, does that change the argument as to, because you have a superior therapy in an 80-year-old, and do you subject them to surgery because of a durability argument? And I think the real world, as you're saying, sort of looks at it differently. They're saying that patient shouldn't get surgery. That patient should get a transcatheter valve.
Interestingly, I must say, and I think you will all agree that the differences between surgery and TAVR in the randomized trial is coming within the 3 first months.
Yes.
It means that
First
this
3
is
months.
definitely procedure related. So
Yeah.
the mortality, the stroke, and all complications are coming because you are doing a very invasive treatment
Bleeding, AFib,
elderly patients. So this is why I believe that definitely in an elderly population at least, whatever the score, TAVR will find its place.
The question is, do we have to repeat all those trials when we go into the 60-year-old, between 60, 70, and look at STS scores, look at high risk, look at intermediate risk, look at low risk? Does it change our perspective?
I think it's very problematic. As I've said in the beginning, the arbitrary distinction of these risk scores has created some dilemmas for us from a regulatory, from a reimbursement standpoint. And we're at the last phase of that. So we've gotten through the intermediate risk category. TAVI is also going to have results in this category as well that I think will be important. Several groups have already begun to study the so-called low-risk category over the age of 65. Very low STS or Euro scores, very few comorbidities. So I think in a few years we'll have data in those patients as well. But in this case, I think you're so correct that clinical practice really has exceeded the clinical trials. And that we've learned that if you can provide a safe, less invasive procedure with improved hemodynamics and with better early outcomes, that it certainly is the preference of the patients. So it's beginning to drive clinical use in a very, very interesting way.
Yeah.
So I think that there are some other issues that we need to be discussing, I'm sure. One is that we've been focusing on the transfemoral patients, but there still is a small cohort where access is very difficult from the femoral arteries. And we've not yet been able to show that in the non-transfemoral patients that the results are any better than open surgery. They're about as good, but they are not any better. So what would you do in the patient that truly does not have femoral access, irrespective of risk, in terms of suggesting that they should have either TAVR or open surgery?
Well, my personal point of view on that, is that the less to do to patients, elderly patients, the best
better.
it is for them. So I think if you can avoid opening the chest, for example, and do a mini-invasive surgery, it should be normally better, well tolerated by the patients, better tolerated by the patient than AV surgery. I think that the main point is to avoid heavy surgery with cardiac arrest and extracorporeal circulation, a lot of transfusion and so on in this elderly population. So I would prefer going through a transthoracic approach like transaortic or transapical.
I think it's quite clear. I would agree with that. Now that we have different options and access sites, I think I would prefer either transapical or direct aortic or subclavian, whatever, over surgical replacement. And we have those options now.
But actually, when we are moving to younger population, like for example 65, 70 years of age, we cannot accept to have any complications, more complications than surgeons. To answer your question, I think that a randomized trial of surgery versus TAVR in a young populations, I am not talking about STS, but the age per se, it would be interesting to check, because the results of surgery in these young populations are excellent, excellent. And not only implanting bioprosthesis, but mechanical valves, in a patient with 60 years of age, for example, we really have to think about the difference between TAVR and surgery, because we know that the surgeons are doing an excellent job with almost zero mortality and very few complications. We cannot accept to have an AR, for example, or to have a pacemaker in a patient patient who is only 60 or 65, if the surgeons can get better results. So this is the main questions in a young population, I think.
Yeah, I mean, I think we had this discussion yesterday as well, you know, who should get surgery. And, you know, I think that the conversation, it has to be individualized, but, you know, a 75-year-old with diffuse coronary disease that's better served by a CABG AVR, it may be one option versus do you do PCI and TAVR in that setting and do multiple procedures. And those are the type of conversations that the heart team is having now, I think in Europe, much more so than are they appropriate for TAVR or not? Is it a better option than surgery, or is surgery a better option? And I think as you go down the age spectrum, they become much more relevant.
So younger patients for sure. The issue of bicuspid valves, have we solved that yet? Eberhard, what are your thoughts?
Exactly. That's what you know. We would see more bicuspids as we move down. I think that's why I was asking the question: do we have to rewrite history a little bit when we move down to the 60s? In terms of, you know, the bar is simply higher on everything that we might be tolerating now in terms of pacemakers, in terms of PVLs, even durability. And if we move down into regardless of risk, into the 60s, I think the bar is high, and we really have to be careful, you know, standing up against surgery because they are doing a great job. And I'm not sure whether we are there yet. Bicuspid valve is one of the morphological issues that we are facing. I don't personally think that any of the valves right now are ideal for bicuspids. I know we can do them all, but whether they are good or suited for this particular entity, I'm not sure, and we don't have any long-term data on that. So, you know, it's going to be a very, very difficult question.
It's a difficult question. It's a very accurate question in this part of the world, because bicuspid valves are more frequent.
Yes.
Yeah. But I must say that I am amazed by the results obtained with the SAPIEN 3. And I think that SAPIEN 3 in a bicuspid valve is certainly better than the results obtained with the previous devices. Actually, I had the pleasure of doing a live case yesterday. It was a typical surgical case, bicuspid valve congenital type 0.
I know, we
with
saw
a lot of
receiver
calcium.
0, heavily calcified.
Yeah, very calcified, and the results with the SAPIEN 3 was good because we didn't have to oversize valve as we did with the SAPIEN XT, for example, so decreasing the risk of rupture, and maybe the skirt is able to prevent the predicted aortic insufficiency coming from the side. So maybe there is a solution with new devices in bicuspid valve. Also, I would say that when we talk about bicuspid valve, you know, we put all the bicuspid in the same basket, and there is a tremendous morphologic difference between type 0, which is the one that I would say would remain in the hand of surgeons, and the other types where there is a raphe that you can crack with the balloon or with the stent with very, very different results. Also, the circumferential opening of the valve in the true type 0 congenital valve could be an issue, which may be solved with high radial forced devices that we have today.
Yeah, I think there's a lot more to learn about even how we classify these bicuspid valves. So, Eberhard, right now, I would argue that the current state of this technology is there's SAPIEN 3, there's Evolut R, I think that are probably leading. But there are also many other designs that people are looking at and that people have tested in clinical trials that you've had access to. Describe some of the devices that excite you in terms of future generations of TAVR.
Well, for sure, it's Lotus.
Yes.
You know, it's neither balloon expandable nor self-expanding. It's kind of a mechanical expansion. The valve has been proven to be very successful, basically in all, you know, required parameters. Pacemaker rate is still higher than the rest, but on the other hand, we have to see and understand a little bit better as we do more patients what the exact mechanism for that is. But there's definitely a valve that goes very, very nicely along, and we see increasing market share of that valve in Europe. We'll see and wait for the results in the United States. So I think that's a very interesting valve. The Jenna valve, even though the numbers are not very high, but a specific indication for aortic insufficiency valves, which none of the existing valves are really very good at. Symatis, direct flow are still there, and they are being sold, and you know, the market share obviously is not so high. each individual, particularly direct flow, maybe might be offering some specific advantages in a subset of patients that have excessive aortic insufficiency, for example, with less anchoring. You can sandwich the valve a little bit better with direct flow in this patient subset. So I think there are valves out there that seem to be promising. The problem is, will they be able to stand the test of time? And I mean, the existing two major players are so far out in terms of experience, data, followed by Lotus. I think it's going to be very hard for those smaller companies, both financially and as far as resources are concerned, to follow up on that.
Sure. And as a center, how many, a lot of centers do 50 a year, right?
I think that's another point. I mean, how many valves can you have in a given center? I would argue that, yes, you need more than one. There are certain situations where one or another may be better suited to a given patient. But it's not like a drug-eluting stent.
Right.
I think you need experience. You need to have a comfort level with a device in terms of sizing and operational characteristics to think you can get the best results. So I would argue that only two, at most three, in any given center.
I agree with that.
Yeah.
I agree with that. I think three is going to would be okay. Granted, and I'm specifically looking at the bicuspids, even though Alain said that the S3 is great for the bicuspid valve. My personal preference is the Lotus in this situation. We have really good results with bicuspid. So I think 3 for individual.
Well, you could reposition it also.
Yeah.
And I think that may be some advantage in some of the bicuspids. So I think that's a very good point. Susheel, you've been involved, and you're the co-principal investigator of the Sentinel trial. So this is cerebral embolic protection. This is a large randomized trial looking at an issue that Eberhard's been involved in for many years now, and we should have results within a month or two. You want to quickly describe the trial and what your expectations are?
I mean, I guess it's a trial. The primary endpoint is an MRI endpoint, just because in sheer numbers, the stroke rates are so low now, you're not going to be able to design a trial to show a reduction in stroke. So the primary endpoint is MRI. Whether that's enough for people or not is a question. But the other intriguing part of the study is there's careful neurocognitive assessment. So even though the stroke rates may not be different, in this older population, can you show a difference in neurocognitive function with embolic protection? Because we know that almost 2/3 of patients have MRI abnormalities. My personal feeling, and I don't know what others think, I think the safety part of this trial is going to be key, because we've all had those cases where we've caught debris. So although the stroke rates are low, it's the sort of the seatbelt concept. If the device is safe and easy to use, then for me, as long as the MRI shows benefit, I think it justifies it, and we would use it. The cost is obviously an issue in many places, so taking the cost out of the picture. I think as long as the MRI endpoint's there and it's safe, whether the neurocognitive is positive or not, which can be challenging in this older patient population who have a lot of cognitive defects to start, for me, it's not crucial. I don't know what...
I agree.
It's a seatbelt for me.
100% agree with you.
I know you've been a strong advocate. Now, Alain is a little bit more of the minimalist school, and I think it would take a lot of data to convince you to use systematically embolic protection.
Well, actually, I'm not convinced at all. I am not convinced at all. I think that this technology should be reserved to a subset of patients, and I guess that in the future, it would be a good indication in the younger population, where you cannot accept to have any kind of stroke or any kind of embolization, even without any clinical manifestation. So.
Well, there's still some controversy in this field, as there should be.
Right.
So I think what we've tried to do in the last 20 minutes is to give people an understanding as to how dynamic and how rapidly changing this field of transcatheter aortic valve implantation or replacement is. That we now have new clinical trial data to suggest to us that we have certainly parity and maybe benefits over surgery in lower risk patients. More randomized trials to come. We have tremendous technology evolution, which has been very exciting for us. With the delivery systems, with the valves themselves, we have the beginning of durability data. We have expanded clinical indications to things like valve-in-valve and bicuspid valve disease in somewhat younger patients. So I think that this has become well beyond what we had originally conceived when Alain back in 2002 put that first valve in. and wondered what is next. I think that it was hard to imagine that a little more than a decade later that we would have progressed to this extent.
Yes, absolutely. I am still amazed, watching this expansion of these indications. Yeah.
You know, there's something that's almost slightly existential about this technology, because every time that we treat one of these patients and you put a valve in and you correct, you eliminate aortic stenosis, it's almost a spiritual event. I mean, these patients do so well clinically. The difference is so dramatic that as a physician, it really gives you a very strong positive feeling. And I think that's one of the aspects that's difficult to explain to people, but it means a lot to the patients.
Sure.
So thank you very much. We have really wonderful discussants, and they're my close friends. And I hope you've gotten a clear appreciation of what the current status is and also some of the future directions of this exciting new valve therapy.
Thank you.